Hi, everyone, and welcome to our Myasthenia Gravis webinar. My name is Arabella Kalinei. I am president of EAMDA, which is the European Alliance of Neuromuscular Disorders Associations. And I am very happy to be your host today. With this series of webinars we are going to organize on a monthly basis. And we kick off today with this webinar dedicated to Myasthenia Gravis disease, especially as June is the month when we try to do a little bit more awareness regarding this serious condition. So I would like just to tell you a little bit about EAMDA. We basically are a European alliance that try to support and improve the quality of everyday life of people with neuromuscular disorders. EAMDA was established in 1974 in London, UK. Later, it was moved to Valletta, Malta, and in 2008 to Ljubljana, Slovenia. And it is still there now. So our office is located in Ljubljana in Slovenia. Sorry to interrupt my speech. Ipek, can you allow the people, or you have problems with this?
No, I am just accepting people, admitting them. No problem there.
Okay, great. Then I will continue. So telling you a little bit more about EAMDA. EAMDA brings together neuromuscular disorders associations across Europe with the aim to advocate the rights and the interest of people living with neuromuscular conditions, to raise awareness, to promote research activities and knowledge sharing, to help reduce the consequences of disability, and to support efforts toward new treatments for neuromuscular diseases. We are proud to be a team of 9 people leading EAMDA from different European countries, and we are doing our best to come up with very engaging activities and activities that will have an impact at the European level. My vice presidents are from Bulgaria, Jana Popova, and from Czech Republic, Dona Jandova. So I do have 2 very dedicated ladies by my side, who are my vice presidents. On the other hand, you could see this lovely lady assisting me here, İpek Badırgali from Turkey, and she's our secretary, but also our communication manager. Thank you, İpek, for your help. And we have people in our team from Croatia, Slovenia, Serbia, and Poland. They are all involved in different activities at European levels. We are all part of different working groups. We try to cover all neuromuscular conditions, but most of us are patients, almost all of us actually are patients ourselves, patients living with a neuromuscular condition. So our activities are very different. We do have an annual international conference that we organize, and we try to get together specialists from all over Europe, but also from other countries in international level. On the other hand, we try to engage all connected stakeholders, because we do understand that only together we can build something that is going to indeed impact the life of patients in Europe. We also organize different webinars. We try to educate as much as we can patients, their family members, the lay public, but all connected stakeholders, of course, as well. We try to create a network, and I will give you a little bit of disclosure. Next year, we plan to build up a scientific advisory board in EAMDA as well, because we do understand that we need to closely work together with medical experts and basically with all connected stakeholders to move forward. We do have different other activities. We plan to organize, for example, Neuromuscular NMD Hub, which will be a resource hub. And I'm very happy that we are already working together with EuMGA, because you will find their information about Myasthenia Gravis as well. We plan to create this hub to be a resource hub also for professionals, not only for patients. So yes, we do have a lot of plans for EAMDA, and we are trying to build up a stronger community. So I hereby salute this new collaboration with EuMGA, and I'm very happy that we are hosting this amazing webinar. I hope it will be an amazing webinar, and you will find very important the information that you will hear. And without any further ado, I would like to introduce Dr. Francesca Cortese from San Filippo Neri Hospital, Rome. Thank you, Dr. Cortese, for accepting our invitation to tell us a little bit more about yourself, your work, but especially about this very complex disease, Myasthenia Gravis. So I really hope you will be able to share your slides. I'm trying to give you share permission, so you will. I think you will be able to share your slides and start your presentation. Thank you for being with us.
Thank you, Arabella. Thank you for this invitation. I'm very glad to be here and to speak about Myasthenia Gravis. I will try to share my presentation. Okay, can you see the presentation?
Yes, we can very clearly.
Yes.
Okay. So I am Dr. Francesca Cortese, and I work in Lazio Reference Center for Rare and Neuromuscular Disease of the San Filippo Neri Hospital in Rome, as you said before. The responsible of our center is Dr. Elena Maria Pennisi, that can't be here unfortunately today. I will speak about myasthenia, diagnosis, classification, and therapy. Myasthenia, as you all know, is a neuromuscular junction disorder. Among the neuromuscular junction disorder, we can distinguish between a genetic and acquired form. Congenital myasthenia is a form of genetic disease of the neuromuscular junction, but I will not speak about it because it would be too long to speak about all the neuromuscular junction disorders. Among the acquired form, we can find myasthenic syndrome, toxic syndrome, and myasthenia gravis. The pathogenetic mechanism of myasthenia was discovered only in 1973. Until then, myasthenia was a fatal disease in 25–30% of cases. Myasthenia is a prototype of autoimmune disease caused by the presence of antibodies against proteins that are located in the postsynaptic membrane. The majority of the patients show antibody against the acetylcholine receptor. Here you see the main mechanism through which the antibodies make damage in the postsynaptic membrane. From the right to the left, you can see the first mechanism, which is the block of acetylcholine receptor. The antibody, as you see, bind the acetylcholine receptor and avoid that the acetylcholine released by the nerve terminal avoid its binding to the receptor. And so it blocks the function of the junction, of the neuromuscular junction. The second mechanism you can see in the central part of the slide is the acetylcholine internalization, the acetylcholine receptor internalization. The antibody binds the acetylcholine receptor, and the favor is internalization, thus reducing the number of receptors on the postsynaptic membrane. The third mechanism that I would like to underline, because it's important for its implication from a therapeutical point of view, is the activation of complements. Autoantibodies are able to activate the complement, which is an important part of the immunitary system. And the activation of the complement leads to the destruction of the acetylcholine receptor and also the destruction of the folding, of the normal folding of the membrane. With losing the typical invagination that you see in the picture. So as we said before, most of the patients show antibodies against the acetylcholine receptor, but a little, about 8% of patients show antibodies against another protein, which is the MuSK, which is a kinase that is located in the postsynaptic membrane, and it interacts with the acetylcholine receptor and helps the folding of the postsynaptic membrane. About 1% or so show antibodies against LRP4, which is another protein of the postsynaptic membrane, while about 5, sometimes 10% of patients show is seronegative. That means that we can't find the specific antibodies. Then we will see why we don't find them. So myasthenia is a rare disease, but if you see the prevalence data, is not so rare. The onset of the disease is from newborn to 90 years old, so it's very variable, the age of onset. There are 2 peaks of incidence. The first is between 20 and 30 years for women, and over 60 for men. But as we said before, it can present in every moment of the life. The main symptom is the fatigue, defined as the early exhaustibility of muscle strength. Usually symptoms tend to regress or improve with the rest, while they tend to get worse after physical activity or at the end of the day. So it is characterized by fluctuation. The main symptoms, apart from fatigue, is the weakness of the muscle eye, the change in voice with the hypophonia, weakness of the facial muscle, drop ahead, difficulty in talking, difficulty to climb stairs, to lift object, difficulty to swallow, the so-called bulbar symptoms we are very worried about, and breathing difficulties. Sometimes the medical practitioners, seeing the first symptom of the myasthenia, send the patient to the wrong specialist, because if the patient presents with ptosis or diplopia, sometimes he's sent to the oculist. Sometimes for breathing difficulty, he's sent to the lung specialist. For swallowing difficulties, he's sent to the otolaryngologist or to the psychiatrist sometimes, because the weakness, the fatigue, and sometimes also the weakness of the facial muscle resemble the symptoms of depression. So sometimes there is a significant delay in the diagnosis of this disease. As you can see in the picture, the symptoms distribution is very typical because face is very frequently involved with the ptosis and diplopia and weakness of the smile, while the proximal part of the arms and of the legs of the lower limb is involved in about 60% of patients. While distal muscle of the arms and of the leg are less frequently involved. Typically, another district which is involved is the weakness of the neck extensor muscle. As we said before, the fluctuation is very typical because sometimes patients wake up in the morning in a good state and develop fatigue in the last part of the day. We can classify myasthenia into subgroups according to different parameters. We can classify it according to the age of onset, so early onset before 50 or late onset over 50. But we have also very late onset and very, very late onset. We see sometimes patients in our outpatient department with an onset over 80s. Then we can classify also with the distribution of the problem, so ocular or generalized. We can classify on the kind of antibody that we find in the serum: anti-MuSK, anti-acetylcholine receptor, anti-LRP4, as we said before, and the seronegative. I will not speak about the drug-induced or neonatal transient for a problem of time. So this cake shows you the main forms, the early onset with the acetylcholine receptor associated frequently with the other autoimmune disease and associated with often with the thymic hyperplasia. And we have late onset forms with an onset after 50 years, often associated with normal thymus or atrophic thymus, and more frequent in men. Then we have forms associated with thymoma. We will speak about it later. LRP4, anti-MuSK, which is a very particular form, sometimes more severe than anti-acetylcholine, with a higher risk of myasthenic crisis. And ocular forms. If in 90% of patients with the pure ocular form for at least 2 years, the disease never become generalized. So this is important from a prognostic point of view. Seronegative patients are about 5–10%. Among seronegative patients, we have also patients that we have tested with the wrong method, because now we have new method to find the antibodies, the cell-based assay, which is very modern and it doesn't use radioactive substances like the radioimmunoassay that is the gold standard. It is more sensitive more sensitive and specific than ELISA, which is used in a lot of laboratories. We have this method, and now it is becoming very much used in Italy, in my country, because it is sensitive, as I said, and it is very important to find to use this method when ELISA is not so when ELISA is not when you first use ELISA to have a confirmation or to have a negative, to get a negative result. Anti-mask myasthenia, as we said, it's a very particular form. It involves for 85% of patients are young females. It doesn't respond to pyridostigmine, but it responds quite well to plasma exchange. Typical is the weakness of the extensor of the neck, of the respiratory muscles, and the involvement of swallowing, so the bulbar involvement. Usually is not associated with the thymoma, and the myasthenic crises are more common, so it's quite severe form. About ocular myasthenia, we can say that patients with ocular myasthenia are more often negative for antibodies. They can show unilateral or bilateral ptosis. In 90% of cases, ptosis is associated with the diplopia, while ptosis alone is present only in 10% of cases. In a good percentage of patients, ptosis and diplopia are associated also with the weakness of orbicularis muscles. Why are eyes muscle so frequently involved in this disease? Firstly, because weakness in the eyes is noticed more often than mild weakness in other districts. Secondly, because there is a reduced number of acetylcholine receptors in the eyes muscles. Also because eye muscles contract more quickly than other muscles, and so they can fatigue very frequently. But also because the eye muscles respond differently to immune attack. In fact, they are also targeted in other autoimmune conditions like thyroiditis. The thymic gland has an important role in the pathogenesis of myasthenia. The thymus is, in fact, an important site for immune regulation. 50% of patients with myasthenia have thymic hyperplasia. More often women with early onset disease, while late onset show normal or atrophic time. And 10–50% have a neoplasia, thymoma in 90% of cases, and carcinoma in 5–10% of cases. So elective chest CT examination with contrast is needed when the disease is diagnosed. The diagnosis of the disease is very complex, and clinical examination is the first and most important part, because it's not useful to ask antibodies if the patient has not the symptoms typical of the disease. Clinical examination use some scale that we will see later. A useful tool is also the ISPAC test, because it has a good sensitivity and specificity. We use a pack of ice, and we put it on the ptotic, on the eye muscle with the ptosis, and we see a transient improvement of the symptoms after the application of the ice. Because the cold can improve neuromuscular transmission. Pyridostigmine test is also very useful. We give oral pyridostigmine to the patient, and we see if it shows a clear benefit. Serology, as we talked before about the search with the ELISA, CBA, or radioimmunoassay of antibodies, so anti-acetylcholine or anti-mask, and so on. And the third tool is the neurophysiological tests, in particular repetitive stimulation or single fiber EMG. Repetitive stimulation simulate physical exertion. In fact, as you see in the picture, the postsynaptic membrane of the patient affected by myasthenia is very different from the healthy subject, because it doesn't show the physiological invagination, and the number of acetylcholine receptor is reduced respect to the healthy subject. And so physical exertion and repetitive nerve stimulation induce a decremental response in the muscle cell, while in the normal subject, as you see in the left, we have a normal response. So all the waves that represent the muscle response are the same. It is very important to avoid self-diagnosis, because we have a lot of differential diagnosis in the clinic. So sometimes we need other examination, like neuroimaging, to exclude other disease, like Gray disease, brainstem disease, or single or multiple cranial nerve neuropathies, or mitochondrial myopathies, myotonic dystrophia, and so on. As we said before, about 80% of ocular myasthenia patients generalized within the first 2-3 years. 90% of patients with pure ocular myasthenia after 2 years will never generalize. And the risk is lower for young people. And after 3 years from the onset of the symptoms, the mortality of the disease was 25–31% before the discovery of the therapy, and now is about 4%. In the management of patients, we have to deal with a lot of problems: diagnostic delay, side effect of therapies, concomitant therapies, and the patients who are therapy resistant. And also we have to handle specific events in the life of the patient: pregnancy, vaccination, preparation for surgery, tumors, and so on. We have also to consider that there are a lot of substances that can interfere with the Oh, thank you. That can worsen neuromuscular conduction. A lot of antibiotics can interfere with the neuromuscular junction function, and also magnesium and the beta blockers, which are very commonly used in cardiology. So we have to pay attention about this. We have to deal also with the coexisting condition, thymoma, or other autoimmune disease like thyroiditis, arthritis, lupus, and so on, and also cardiac disease. And therapy-induced disorder. We have to remember, as you probably know, the side effect of steroids. Unfortunately, steroids are very rapid, have a very rapid action in this disease, but they can induce the elevation of the blood pressure, elevation also of the eye pressure, osteoporosis, weight gain, elevation of the glucose level in the blood, and sometimes diabetes. The long-term effects are very problematic. Here we see the classification of the severity of the disease. We have the class 1, which include only the ocular form. Class 2, 3, and 4 include the generalized myasthenia with the mild, moderate, or severe weakness, respectively. And we have an A or B form, with the B form that affect with the patient affecting the patient with the involvement of oropharyngeal and respiratory muscle or both. So the B form is more severe than the A form. Usually in a clinical examination, we use a different scale to understand the severity of the disease. In the right, you can see the EuMGA quality of life with the 15 item score. It is a self-administered scale in which the patient write the interference of the disease with his daily life. EuMGA is very useful because it is important. It is useful. It is used in a clinical trial. Also, quantitative MGS. EuMGA measure the effect of the disease on 8 items: talking, chewing, swallowing, breathing, and so on. While quantitative MGS is a real quantitative scale that it is performed by the clinician, because we measure with the chronometer the seconds in which the patient is able to keep the leg and the arm outstretched. We measure the seconds in which the patient can keep the head lifted. We measure also the seconds after which we can see the onset of the ptosis and of the double vision. And we can see, we can measure also with the dynamometer the strength of the hand grip, the left and the right hand grip, and also with the spirometer, the vital capacity of the patient. So it's a real quantitative scale. I don't know, I can't go up. Okay, let's speak about the myasthenia therapy. Conventional treatment options for myasthenia are inhibitors of the acetylcholinesterase, useful as a symptomatic treatment. Immunosuppressive drugs, the main treatment of the disease. The problem of these drugs are the fact that they are not specific against the disease, so they can induce opportunistic infection and the collateral effect in other organs, and the onset of action of the immunosuppressive drugs is delayed. Immunomodulatory drugs like intravenous immunoglobulins and the plasma exchange, they are used in the acute worsening or myasthenic crisis, and thymectomy in patients with thymoma, or also in patients younger than 65 with the acetylcholine receptor antibodies. This is a list of the main immunosuppressive drugs that we use in myasthenia. As you can see, azathioprine can induce liver toxicity, leukopenia, nausea. Mycophenolate also, it can be teratogenic, it can induce leukopenia. So they can have a very important side effect. Furthermore, azathioprine starts to act about 6 months after the starting of the therapy. So the patient needs to be exposed to steroids for a lot of time. So there are unmet needs in myasthenia therapy. Conventional therapy induces remission in 70–80% of cases, but they impose the risk of long-term exposure to non-specific immunotherapies like opportunistic infection, malignancies, and organ dysfunction. And they need prolonged therapy with the corticosteroids, with their metabolic effect that we talked before. A subset of the myasthenia gravis patient, about 10–15%, may be classified as treatment refractory. So they don't respond to standard immunotherapies, or they relapse or show crisis during therapy, or they have intolerable side effects of from the medication. So in the last years, a lot of new medication have been launched in myasthenia therapeutic trials. They use new important mechanism, in particular the inhibition of complement pathway and the inhibition of the neonatal FC receptor. And the third mechanism is the inhibition of the direct inhibition of B or T cells that are lymphocyte involved in the immunitary system. A few of these drugs have obtained approval from a regulatory agency, while the majority are in various phases of development. Here we can see the main mechanism we talked before. Complement is an important part of immunitary system that activates chemotaxis, so activate calls, as we can see, the other cells of the immunitary system, and activate the lysis of the bacteria. In this case, for myasthenia, it activates the destruction of the acetylcholine receptor. So its activation is not so good for the patient. And so complement inhibition prevent its cleavage and the activation of the other component of the cascade, of the component cascade. The second mechanism that is used by this new drug is the inhibition of this neonatal receptor of the immunoglobulin G. Usually, immunoglobulin G binds this receptor, this neonatal receptor, and they can be recycled. So they are saved from cleavage. Antagonists of this receptor are useful because they increase the degradation of the immunoglobulin G, and so they act like a plasma exchange without the collateral effect of the plasma exchange. The third mechanism is the depletion of B cells that you know are involved in the production of antibodies and of T cells. Here you see the list of the approved myasthenia gravis treatment, novel treatment. Eculizumab, ravulizumab, and zilucoplan are block. Their mechanism is to block the complement, the protein C5 of the complement. While efgartigimod and rozanolixizumab block the fragment crystallizable neonatal receptor, so the neonatal receptor or the immunoglobulin G, increasing their degradation. Let's speak about them briefly. Eculizumab is a humanized monoclonal antibody against the fraction C5 of the complement. Eculizumab prevents the formation of the membrane attack complex and the reduced damage caused by the antibodies against anti-acetylcholine receptor. It was approved for myasthenia only in 2019, but it was used before for other diseases in which the activation of the complement was very important in the pathogenesis of this disease. According to the international consensus guidance for management of myasthenia gravis, eculizumab should be used in a severe form of anti-acetylcholine antibodies positive patient and should be considered after trials of other immunotherapies. Vaccination against Neisseria meningitis is required because there is a low risk of meningococcal infection. Ravulizumab is a sort of evolution of eculizumab because it's a long-acting complement inhibitor, and so it is more comfortable for the patient because the long half-life necessitates fewer infusion for the maintenance therapy. Zilucoplan is a small peptide. It's not an antibody, but a small peptide which prevent the terminal activation of the complement cascade. The advantage are the small size, so in the good penetration, the possibility to use a concomitant therapy with the intravenous immunoglobulin, and the self-administration, but requires daily administration. Efgartigimod is a neonatal Fc receptor antagonist. So, as we said, antagonists of this receptor prevent binding of immunoglobulin to this receptor and increase their degradation. They can provide a safer and more convenient alternative to plasma exchange. And all IgG subclasses are decreased by this antagonist. And this data is very important because it has a potential application for all the forms of myasthenia. In fact, rozanolixizumab, which is a neonatal Fc receptor antagonist, was tested also in a patient with anti-MuSK receptor, and it demonstrated efficacy. So it can be used in both kind of patient. Rituximab is an old, a very old drug that has been used for myasthenia for several years. It is very useful for anti-MuSK patient, but recently it was shown also to be effective for anti-acetylcholine receptor patient. Usually is quite safe, but sometimes can give headache, nausea, flushing, pruritus, so it needs pre-medication. Usually before starting treatment, it requires a check for hepatitis B, hepatitis C, and tuberculosis, and the complete blood counts because it can induce cytopenia and the reactivation of hepatitis and tuberculosis. It can decrease the efficacy of vaccines, so the vaccination should be given at least 4 weeks before treatment if possible. So there is a summary of what we said. You can see rituximab, B-cell, which is a B-cell directed therapy, eculizumab, which is a complement inhibitor administered weekly for 5 weeks and then every 2 weeks. Ravulizumab, which is administered every 8 weeks, so it's more comfortable than eculizumab, and zilucoplan, which is administered subcutaneously daily. And then the neonatal Fc receptor antagonist, efgartigimod, administered intravenously, and rozanolixizumab administered subcutaneously. So we have a large panorama in the treatment of myasthenia. We have to distinguish between ocular and generalized form because the treatment is quite different, and also between seronegative, anti-acetylcholine, and anti-MuSK patient, because for example, complement inhibitors are useful only for anti-acetylcholine receptor and antibody positive patients. And the treatment of myasthenia gravis is obviously very different because it requires an admission in intensive care unit and plasma exchange, immunoglobulin, and probably the new drugs that we talked about before can be useful in this phase. In fact, there are some reports in the literature that show good effect of these drugs because they are very rapid with the onset of the activity is very rapid. We have a lot of new molecules that are in various phases of development. Now I will rapidly show you these tables. So after eculizumab, ravulizumab, zilucoplan, we have a lot of these other drugs in experimentation. Also among FcRn blockers, there are a lot of other molecules in various phases of development. Also B-cell targeting therapies after apart from rituximab, we have other drugs. And here we have also in phase 1 and phase 2 other molecules against chemokine and cytokine pathway, but we are still far from their approbation. Other mechanism, this can be a very fascinating new mechanism, because this technique involves the harvesting of T cells from the patient, modify the T cell receptor, and when the T cells are infused, they modify the receptor, bind specific antigens on B cells and destroy them. So it's very new technique, new mechanism. But still it's not used for myasthenia. Experimentation is ongoing. The novel biological therapies are targeted to specific pathophysiological mechanism of the disease. They are not unspecific like immunosuppressive therapy or steroids. They are very useful in patients with refractory myasthenia and can be used also for rescue therapy, because the onset of the activity is very requires sometimes few days. They can be helpful in patients with comorbidities and the relevant side effects from steroids or conventional therapies. Long-term side effects and efficacy need to be clarified, because we have been used them only for a few years, and their high cost unfortunately prevent access from many patients. And the accumulation of real-world data will help us in the logical placing of the drug in the treatment protocols. I thank you very much for your attention, and these are our contacts if you need something. Thank you.
Thank you so much, Dr. Cortese. It was an amazing presentation with a very comprehensive one with a lot of interesting things. And yes, actually, I do have myself a couple of Romanian friends with Myasthenia Gravis. One of them is here with us. She's president of the Romanian EAMGA Association, Adriana Harja. So I am a bit familiar with these conditions, because they told me a little bit about it. It is indeed a very challenging condition, and we are so happy that doctors like yourself, Dr. Cortese, are here to help the patients. We have, in Romania, we have such doctors as well, like Dr. Cristina Vâlciu, who I think she's also here with us, and she honored us with her presence in EAMDA's last year conference when we organized it here in Bucharest. So this is something very important, the fact that we do have a lot of passionate doctors that are there to help patients, and for sure you are one of them. So thank you so much for this presentation. I will then move forward with our next speaker, but Dr. Cortese, will you be able to stay until the end so you can maybe answer 1 or 2 questions, or?
Sure, I will stay.
Great. Then we'll move to our next speaker, to Dimitris Zaftis. Hi, Dimitris. So nice to have you with us. I know you're a secretary and board member of this newly established EuMGA, which is a great initiative, a European initiative, and I am also very proud that my colleague Adriana is there with you in this amazing organization. And as we have learned in EAMDA only together and united and sharing our experiences and expertise, we can create something that will have a great impact at European and national level. So thank you so much for joining us. Could you please tell us a little bit more about maybe a little bit about your personal experience with myasthenia gravis, and but mainly about what EuMGA is doing at European level, about what you plan to do, and why it is important for organizations from different countries and patients to be there close to EuMGA.
Yes, thank you so much for the invitation and having me here today. I also want to congratulate Dr. Cortese for your thorough and detailed presentation. And let's go ahead and let me introduce myself at first. I'm Dimitris Zaftis. I'm the secretary of the EuMGA, as you already said. And I'm a Greek patient. I'm coming from Greece. I was diagnosed with the disease when I was 16 and a half years old. Now I'm 57. And I have been through all those changes that Dr. Cortese has described in her speech, and have all those problems and issues that patients with MG have. So I won't say anything more about me. I'd like to focus on introduce the EuMGA. For those who may not be familiar with us, let me offer you a concise introduction. So EuMGA is short for the European Myasthenia Gravis Association, serves as a pivotal hub for Myasthenia Gravis national associations across the European Union. Now, as a non-profit organization, EuMGA is dedicated to providing crucial information, support, and raising awareness for individuals affected by MG throughout Europe. Our journey began with a collective vision shared by a group of MG associations. We aim to make a profound difference in the lives of those living with this condition. This vision laid the foundation for EuMGA, and today we stand as a united front committed to this cause. EuMGA was founded with a paramount goal: to unite MG associations across the EU and to encourage the formation of new ones where none exist. Simultaneously, we dedicate ourselves to elevating the knowledge of expertise of healthcare professionals while addressing the unmet needs of MG patients. Additionally, we strive to procure the most up-to-date information regarding new MG medications and treatments. Our first strategic initiative is the European Patient Advocacy Committee. This committee serves as a collaborative platform open to all MG patients residing in Europe. It is a space where patient-led initiatives can flourish, supported by a dedicated social media team of volunteers working to enhance our outreach and impact. We recognize the importance of fostering a new generation of advocates. Our young patients group is specifically designed for young European MG patients. This group develops and leads projects empowering young individuals to become the advocates of tomorrow. Collaboration is in the heart of our efforts. We are engaged in ongoing partnerships with esteemed organizations such as Eurordis, EFNA, and the EAMDA, of course. Through these collaborations, we enhance our advocacy and awareness efforts. We also actively support EFNA's manifesto, encouraging widespread endorsement and action. To unify and amplify the voice of MG community, we lead the All Unite for MG campaign. This initiative is designed to bring together voices from across Europe, strengthening our collective impact and visibility. In today's digital age, a dynamic social media presence is vital. So we have successfully launched various social media platforms to connect and engage with the wider community. fostering a sense of unity and a shared purpose. One of our unique contribution is initiating support projects for countries that lack MG associations. By fostering the establishment of new national organizations, we extend our reach and support to those in need. Through EuRORDIS, we collaborate with the European Medicine Agency, the well-known EMA, to manage national emergencies, address medication shortages, and provide feedback on critical medication lists. This collaboration is crucial in ensuring the availability of necessary treatments. To tackle medication shortages effectively, we maintain ongoing updates and unified strategies. This proactive approach ensures that we are always prepared to address challenges as they arise. We are committing in enhancing advocacy skills and knowledge by providing continuously updates and resources for training courses on patients' advocacy, health technology assessment, and drug registration. Empower our community to become well-informed and skilled advocates. Our commitment to global solidarity is exemplified by our humanitarian efforts. We have extended support to myasthenia patients in Ukraine through mediation by the Polish Association face-to-face. This initiative underscores our dedication to providing assistance whenever it is needed. Lastly, we collaborate and consult with pharmaceutical industries to enhance community advocacy boards. This partnership is vital in ensuring that the voices of MG patients are heard and considered in the development of treatments and policies. In conclusion, EuMGA is unwavering its dedication to improving the quality of life for those affected by MG. Through collaboration, advocacy, and awareness efforts, we aim to make a significant impact on the MG community across Europe. Together, we believe the power of unity to bring about meaningful change. So thank you for listening, and hope this clarifies things about what MG is and what its purpose right now is.
Thank you so much, Dimitris. And as I said, we know that only together we can help more patients like us. You know, I myself, I am a Charcot-Marie-Tooth patient, and it was my dream to try to help others. You know, because I became empowered back when I got in touch with some European and American organizations, and I took my knowledge and expertise from them, and I understood that you have to build up in a community, in a patient's community, and do it not only at national but also at European and international level. This is how things are changed for the better, for a better future and for a better quality of life for patients. So and I know that you're doing an amazing job, and EuMGA is just starting in a way, but I know you will have a major impact, and hopefully also at the national level, because even in Romania we do have a lot of challenges, and I'm sure these challenges are all over, you know, in other countries like Eastern European countries especially. Yes, so but it's so encouraging to see that all these efforts, and especially when you combine the efforts of patient organizations with medical experts, with even pharma and all relevant stakeholders. And when you also get the support from your government, from the Ministry of Health, from the institutions, then it's even better. So thank you so much for telling us more about what you are doing at European level. And I would like to dive into the questions now. Dr. We will start with ladies first, okay? So we will start with Dr. Cortese, as she was our first speaker. And Dr. Cortese, I would like to say that Actually, I would like to ask you about the unpredictable nature of myasthenia gravis. I know it can be particularly burdensome, especially for newly diagnosed patients who may struggle to differentiate between minor fluctuations and serious exacerbations of the disease. What advice do you offer to your patients to help them manage this uncertainty?
Thank you for the question. Firstly, we have to distinguish between fluctuation of the disease, which was defined as a transient worsening of the symptoms of the disease with little or no interference with the daily activities. And it can be temporarily managed with the minor adjustment of the basal therapy. While exacerbations are more serious because they represent a significant worsening of the symptoms of the disease with a profound impact on the daily activities of the patient. So I think that patients, especially newly diagnosed ones, needs to be guided by the clinician. So if they have any doubt, usually we ask patients to address to us, to phone us, to send us an email, and to come for a neurological examination, because we would like to help them in this difficult evaluation. For us, the most relevant symptoms are the bulbar symptoms. So the problems in swallowing because of the risk of inhalation and pneumonia, and the respiratory problems because they may herald a myasthenic crisis. And in this situation, the patient needs to perform an urgent neurological examination.
Okay, thank you so much. I've also seen that we do have a question in the chat, but I think it was put during your presentation, and it was regarding, I don't know if you can see our chat, Dr. Cortese. They were asking about, well, I think it's the administration of a treatment, if it is better to administer it when the patient is deteriorating rather than in crisis.
To administrate, to administrate?
When the patient is deteriorating rather than in crisis, but I'm not very sure. Maybe, I don't know who wrote the question. Maybe could you open your microphone and clarify?
And so hello everyone, I'm from Bulgaria. I'm presenting and helping Irena. She's the head of the organization of Bulgaria, but I'm also with Myasthenia Gravis. Okay. So I'm helping her with the translation. So she asked these questions about the side effects of all of the medication, because in the presentation with Dr. Cortese, there is no information about the side effects. And also Irena is asking, isn't better to use the medication when the patients are very bad, not when they're in crisis? That's the two questions of Irena.
I don't know if I have understood. You were talking about using medication when the patient is bad and not when the patient is in crisis.
Yeah. Yeah.
Sure. Definitely, we try not to avoid the myasthenic crisis, because we usually. Sorry.
No, I'm translating. That's why I'm speaking.
Okay. So usually when there is the first sign of worsening of disease, we see the patient as soon as possible, because we try to avoid the myasthenic crisis. Sometimes, unfortunately, since the diagnosis is very delayed, patient come to our outpatient department too late, when they have respiratory symptoms, very important respiratory symptoms, and so the starting of the therapy is not enough quickly to avoid the myasthenic crisis. But fortunately, in our center, we can manage the problem before the onset of the crisis. So we can avoid a lot of crises, fortunately, because we have a contact with patient, with mail, and with phone. With phone, we have a dedicated nurse that help us in the organization also of dysphagia and respiratory assessments. So we try our best to avoid the myasthenic crisis. We obviously, when the patient present in emergency department with the myasthenic crisis, because sometimes he doesn't know to have this disease. The diagnostic delay is very big sometimes, because the medical practitioner send the patient to the lung specialist when he has a respiratory problem, and it doesn't think about a neurological problem at the beginning. So I think that most of myasthenic crises are due to diagnostic delay, or to the fact that the patient can't have rapid access to the clinician. So I think it's very important communication with the clinician as quickly as possible if the patient has a doubt.
Thank you so much. Thank you.
Thank you for the question.
Just because you mentioned that communication is very important to with the doctor, I'm also curious, does it help for the patients to have to keep a record of their symptoms, try to track maybe their symptoms, what triggers them?
Sure. It's important that the patient take, it is helpful to consider, I think, a specific task in the daily life of the patient, because I can't ask the patient to measure how many seconds he can stay with the arm outstretched or with the leg outstretched, because it's not easy. But the patient, if, for example, he lives at the first floor of an apartment, I can ask patient if he notice any variation in dyspnea or in fatigue when he arrives in his apartment by stairs. Or I can ask a patient, or the patient can record if he notice any variation when he combs his hairs or brush teeth. So in the daily life, and also when he notice the presence of ptosis or diplopia, he needs to record when, in the morning or in the evening, after exertion or at rest. And also about dysphagia, it's important that the patient notice for which food he noticed dysphagia. So for dual consistency, for solid food, for more soft foods, or for liquids. For us, it's very useful. And also if he has a respiratory problem after 3 steps, or after 1 floor of stairs, after 2 floors of stairs. So we have to tailor also this task in the daily life of a patient, because there are also patients that like sport, and so they noticed before if there is a variation of this of their ability to do something, and the patient in which the daily life is quite different, but they can notice variation in the small things. Anyway, as I said before, it's important the communication. We ask a patient always to write an email or phone if they notice variation in their daily task. I mean, is the most important advice that I can give the patients.
Okay. Thank you so much, Dr. Cortese. Are there any other questions for Dr. Cortese in the audience? Yes, Dimitris.
I have no question. I actually want to say that maybe a good solution would be to implement digital biomarkers in order to track symptoms between two appointments before the doctor actually can see you again. So tracking those symptoms, the symptoms of the patient like this could provide a more objective image of what has happened in the previous time frame between the two appointments. It's just an observation, nothing to say for. There is no question about it for this. Okay.
What do you mean with the biomarkers? You mean also antibody detection or only symptoms reported?
Like I don't know if this is applicable in the EuMGA. I mean, you can use like a watch or you know, those digital watch now that can be used in sports to actually catalog what has happened in the previous time before the appointment, like having maybe a deterioration in their walking, or maybe like you can measure the steps or something like that. I don't know how this could be applicable. I'm not a technician. I'm not a guy that is in computers science. Maybe it's something for the future, actually.
Yeah, sure. Could be useful to decide some specific task. I think that also the ADL, EuMGA is useful for this task, because we ask patient specific task in the last days, if they notice problem in arising from chair, or in comb hair, or in rising object, or in swallowing, in diplopia, and so on. But I think that other scales can be useful, because for example, walking is not considered in ADL, in EuMGA, so it's not complete. Usually we use a different scale during the clinical evaluation, because it's important both the quantitative estimation and the point of view of the patient, so also the impact on his quality of life. But surely also biomarker could be useful. Also the repetitive stimulation, if we have any doubt, can be helpful to understand if there is a worsening of the disease, or there is, for example, myopathy induced by steroids, because sometimes we can have doubts about it, and so we require a specific examination. I think that if the clinician has a doubt, it's useful to repeat neurophysiological test, for example, but I don't think that it is helpful to do it every time we see the patient, because it's not so, the patient is not so glad to repeat frequently repetitive stimulation. Sometimes it's painful, and so for for the neurophysiological test, I think there is a specific, we need a specific question addressed by the clinician. Regarding the antibody detection, it can be useful in the single patient, but we don't use commonly because the level of antibodies is not always correlated with the clinic. Maybe there are some correlation in the single patient, but not between a patient and another. So we need a more specific biomarker and also specific and more specific scale, maybe.
Thank you again.
Thank you. Thank you for the question.
I still see a raised hand.
I'm sorry, just to ask the first question of Irena, which is what are the unexpected side effects from all of these treatments, the new medication?
You want to know the side effect of which of steroids you mean? Or
От кое искаш да знаеш страничните ефекти? От кой тритмент?
От тези, които представи, има ли такива, които очакват или няма такива?
Ами, защото те са много. И те питат
Добре,
от кое.
ЕВГ и мода.
ЕВГ и мода.
Евгер Стигемот от него.
Okay, she wants to know about the EuMGA, about the side effects. Yeah.
Usually is well tolerated. Sometimes it can induce allergic reaction, but they are very rare. And the most important problem are some infection. But the risk is not very different from placebo because it reduces only the quantity of immunoglobulin, so it can induce respiratory infection of the upper tract, and the most frequent are infection of the upper tract or gastroenteritis. But before starting therapy, we ask the dosage, the level of immunoglobulin in the blood of the patient, because if the level is too low, we can't start this medication. So I can say that it's quite safe until now, because we don't have very long-term effect, but because we have been using for a few years, so allergic reaction can be present as in all the drugs.
Thank you so much for your answer.
Thank you.
Yeah, thank you so much, Dr. Cortese, for sharing so many useful information. And I would like to move to questions for Dimitris, if there are any. Yes, Ipek?
Thank you, Arabella. So, Dimitris, thank you for the information, and also congratulations for establishing such important organization. And I think that you are now creating a community, and you see the unmet needs in your community. Most of the people with NMD are struggling with unmet needs. And can you also elaborate on unmet needs, and how do these unmet needs affect people living with myasthenia gravis?
Yeah, sure, of course. So one major challenge the MG community faces is delayed diagnosis. That happens to a lot of rare disease, actually. So many neurologists are not fully aware of MG and its symptoms, leading to many cases being overlooked or misdiagnosed. This lack of awareness means patients often go through long periods of uncertainty and incorrect treatments before receiving an accurate diagnosis. Early symptoms of EuMG, such as muscle weakness and fatigue, can be mistaken for other conditions, further complicating timely diagnosis. Another significant challenge is the lack of recognition and understanding of EuMG. Patients frequently encounter stigma, discrimination, and exclusion from employers, health services, and society at large. This social stigma makes it difficult for them to access necessary support and accommodations. EuMG patients and their family often feel dismissed and not taken seriously when seeking help, which can lead to isolation and additional emotional stress. Accessing support networks and care is another major hurdle. EuMG patients consistently report difficulties in finding the information and support they need. This problem is exacerbated by a rural-urban divide, where patients in the rural areas face greater challenges in accessing quality care compared to those in urban areas. While social media has provided new opportunities for support, enabling patients to connect and find comfort from others regardless of location, it is not a complete solution. I believe I covered your question. I don't know if you need anything else to add.
Thank you. Much for the same with other diseases. Thank you.
Thank you, Dimitris. Actually, I also have a question for you because I was speaking about national health systems before, and we all know that navigating healthcare system is quite tricky in many countries and not easy for patients, especially newly diagnosed patients. So I'm wondering if you can discuss a little bit about the challenges that patients have when trying to navigate their healthcare system, especially at national level, and if you see some solutions for, I don't know, give some solutions, some advice to improve this navigation for patients.
Yes, thank you for your question. This is a condition that happens a lot, a situation that happens a lot lately. I mean, having troubles with navigating through the pathways of national healthcare systems. So, as I already mentioned, EuMG symptoms are diverse and can fluctuate, making diagnosis even more challenging. Symptoms like weakness and fatigue are non-specific and can vary greatly from patient to patient. Additionally, mental health issues are common among EuMG patients, further complicate diagnosis, as these symptoms can lead to misdiagnosis of depression or anxiety rather than recognizing the underlying EuMG. This can then send patients on frustrating and ineffective paths around specialists, the so-called diagnostic odyssey, or even leads to them being sent home with a prescription for antidepressant or anxiety medication rather than an EuMG diagnosis. To address these challenges, the EuMGA aims to facilitate the establishment of centers of expertise in every EU country. These centers would provide neurologists with the necessary information and tools to better manage EuMG cases. The EuMGA also seeks to leverage a network of healthcare professionals who have EuMG themselves to raise awareness among non-specialists. However, the mission goes beyond neurologists, actually. General practitioners, GPs, as they are well known, need to be well informed about EuMG to ensure that refer patients with potential symptoms to specialists promptly. Dr. Cortese already mentioned that. So, therefore, instead of focusing heavily on educating all physicians, we propose a more effective approach. Empowering EuMG patients and their families with the knowledge they need to inform their doctors. This strategy strengthens the support network for already diagnosed patients and ensures that they receive more accurate and timely care. By empowering patients and their families to bring well-informed insights to their treating physicians, the community can overcome some of the educational and awareness barriers that currently exist. This approach helps to ensure the patients receive the right diagnosis and treatment more quickly, improving their quality of life and potentially slowing the progression of the disease. I mean, this is the real problem. We have already tried that to educate specialists and physicians in general, but that is something quite difficult to be done. Even the industry that the pharma industry have already tried that in a lot of ways. It's a steep hill to climb, but so far doesn't have the outcome that we hopefully would hope they hope to. So it is better for us. I mean, it's a more actually real approach to better equip our patients with the necessary tools and the knowledge to address themselves their needs, and of course inform their GP or neurologist or any kind of physician to what actually is more important for them and what actually they feel they need more and how their condition is now progressing.
Okay. Thank you so much, Dimitris. Are there any more questions for Dimitris from the audience? Okay, if not, because we promised a 1.5-hour webinar, we want to wrap up a little bit with a summary of what was discussed, first of all. So, but let me just say that, you know, I'm being patient with Charcot-Marie-Tooth disease. Actually, I can understand a lot Myasthenia Gravis patients, because two major problems that I also have is muscle weakness and fatigue. This is something that sometimes I don't even know how to deal with them anymore. So I really think that it is important to really understand the burden of the patients, because it's really a challenge, an everyday challenge to try to live and to accept and to live with such a neuromuscular condition and with such neuromuscular conditions. They affect our everyday life and they affect our inclusion in the society. They limit us in so many ways. But there is still a lot of hope with the fact that we have, as I said, dedicated doctors with us. We have a lot of people trying to help us and to raise awareness and to push research, so we will have treatments. You are lucky enough, because on Myasthenia Gravis you do have some treatment options. On CMT, unfortunately, we don't have. And there are so many even more critical neuromuscular conditions like DMD or ALS that are so burdening for the patients and for the families, and they still don't have treatments. And this is not, I mean, it's something that we can just hope for, that all our efforts at one point will lead to treatments and to a better quality of life. So thank you so much for attending this webinar, and let me just remind you of a few key points. So the fact that we heard a lot today about the importance of patients being correctly and early diagnosed and referred to a good specialist who has expertise. I mean, patients need to be seen by specialists that have expertise in Myasthenia Gravis to ensure the best treatment option and the best care for them. Of course, there will be always unmet needs and a lot of challenges, like these side effects of the therapies. but still, I think with the right guidance and with a good collaboration with your medical professional, this is also a disease that can be somehow addressed, somehow managed, basically. I would just want to say that together we can overcome the challenges and improve the quality of life of patients with myasthenia gravis. And as for EAMDA, for sure, we are going to try to remain connected and closely connected with EuMGA and come up with different projects. I mean, EAMDA, as being the European Alliance of Neuromuscular Disorders Associations, we are here to help. So we stay committed to all the NMD community to try to support and put all our knowledge and networking and all resources we have to the benefit of patients and patient organizations. So once again, thank you so much, Dr. Cortese and Dimitris, and all of you who participated, who took your time to participate to this webinar. For sure, we will let you know about our future webinars on different other diseases, but also some common challenges that all neuromuscular conditions face. And I cannot but wish all of you a great afternoon. And please stay connected to EAMDA. You can easily find us on all social media and on internet. And we do have a good communication manager that will help us stay in contact with all of you. Thank you, EPEG, for your help.
Thank you.
And thank you. Thank all of you for participating today.
Thank you for your attendance. And can we make a group photo? If possible, everyone can open their camera and then we can take a group photo.
Thank you. Thank you so much for this
open the camera yet.
webinar.
So it would be nice to end up with a group photo. So anyone listening, can you open your cameras maybe for a few seconds to be able to take a group photo?
I will take one. Thank you so much.
And one last thing. Okay, people are still opening the camera. Maybe you can still take some photos.
Sure. So I am making again.
And one other thing I would like to recognize before we close the webinar is the fact that there are all these committed pharma companies that stand by us, and especially I would like to thank for this for the support, even for organizing this webinar. AstraZeneca and Alexion, we are having a great collaboration with them. And I know they are supporting MG patients. Again, as I said, collaboration with all stakeholders, it's very, very important. So have a great day, everyone, and thank you for attending today.
Thank you very much.
Thank you.
Thank you. Thank you so much.
Thank you so much.
Bye-bye.